Welcome back to part 7 of the Shoulder Arthroscopy and CPT Coding Mastery Explainer. Today, we're diving straight into the audit-proof documentation requirements for loose and foreign body removal in the shoulder joint. If you've ever had a claim denied for CPT 29819, well, you know exactly how tricky this seemingly straightforward procedure can be. Here's our roadmap for today. We've got a quick masterclass recap, then we'll break down pathology, loose versus foreign bodies, dive into the 0.5 centimeter golden rule, tackle concurrent procedure coding, hit an interactive knowledge check, and finish up with our key takeaways and the next episode.
Let's kick things off with Section 1, Masterclass Recap, Setting the Stage.
A super quick refresher on our last explainer. We covered the precise clock positions on the glenoid bone. Remember, slap repairs, billed with CP2 29807, hit the upper half of the labrum from the 11 to 1 o'clock position. Bankart repairs, that's CP2 29806, cover the lower half from 1 to 11 o'clock. Now, our mission today is layering on the strict rules for extracting loose bodies during these exact types of arthroscopies. Moving right along to Section 2, Pathology, loose versus foreign. So what exactly are surgeons hunting for in that joint space? We basically separate the organic from the inorganic. Loose bodies, those are your organic materials, things like fragments of articular cartilage, detached osteochondral fragments, or broken bone chips just floating around or lodged in a recess. Foreign bodies, on the other hand, are the inorganic items. Think dislodged surgical hardware, maybe loose suture anchors, or broken pins from prior surgeries. But whether it's a bone chip causing mechanical locking or a rogue suture anchor causing synovitis, these fragments bring on intense localized pain and actually accelerate cartilage degeneration. They have to come out. Next up, Section 3, the 0.5 centimeter golden rule. The official descriptor for CPT 29819 sounds incredibly simple. It's just arthroscopy, shoulder, surgical, with removal of loose body or foreign body. Sounds easy enough, right? Well, not so fast. As expert coders, we know the documentation has to definitively prove a dedicated extraction. You simply can't bill this every single time the surgeon washes out the joint. So, here is the golden rule you absolutely need to memorize. This code is assigned only when the loose or foreign body is equal to or larger than the diameter of the arthroscopic cannula itself. Or, and this is key, it's explicitly documented in the operative note as being greater than 0.5 centimeters. That's 5 millimeters. If that precise size threshold isn't clearly documented, the code simply is not justified, period. And that brings us to a huge pitfall. We absolutely cannot report 29189 for routine small debris or tiny cartilage shavings that are just suctioned away through a shaver during normal debridement. No way. Reporting this code requires the use of separate grasping instruments, an enlargement of the portal incision, or the piecemeal extraction of large fragments. The retrieval work has to be completely distinct and substantial. All right, Section 4, Concurrent Procedure Coding. Now you might be wondering, can we bill this with other procedures? Yes, you can absolutely report 29819 alongside major surgical arthroscopies. So if the surgeon is doing capsulorrhaphy, CPT 29806, or a rotator cuff repair, 29827, you can bill for the loose body removal too. But, and this is a massive but, you can only do this provided the fragment meets that golden greater than 0.5 centimeter threshold, and it required dedicated separate retrieval work. It absolutely cannot just be incidental debridement while prepping the labrum or the cuff for repair. Let's put this all into practice with Section 5, Interactive Knowledge Check. Okay, let's look at a real-world clinical scenario. The surgeon performs an arthroscopic anterior labral repair, a Bankart repair, along with some localized debridement. During joint exploration, they spot a free-floating, cartilaginous loose body measuring 7 millimeters in diameter sitting down in the axillary pouch. They grab it with an arthroscopic grasper and extract it right through the cannula. So take a second and think about it. What CPT codes should we report here? If you guessed 29806 and 29819, you hit the nail on the head. Code 29806 covers the capsuloatrophy for that anterior labral repair, and code 29819 is fully 100% justified. Why? Because 7 millimeters is 0.7 centimeters, which easily clears our audit-proof golden rule of being greater than 0.5 centimeters. Plus, the operative note explicitly stated an arthroscopic grasper was used for a dedicated extraction. Perfect documentation. Wrapping up with Section 6, Takeaways and Next Episode. To wrap this all up, just follow these 3 strict steps to make sure your 29819 coding is perfectly compliant and completely audit-proof. 1. Identify the pathology. Is it a true loose or foreign body? 2. Verify the size documentation. Is it explicitly documented as greater than 0.5 centimeters or larger than the cannula? And 3. Confirm that dedicated extraction instruments were utilized, ruling out just routine suctioning. And that brings us to the close of Part 7. But get ready, because next time we're tackling something even trickier. Ask yourself, at what exact anatomical point does a partial synovectomy cross the line into a complete synovectomy? And how does the underlying diagnosis change the entire coding strategy? We are going to decode all of that in Part 8 when we cover synovectomy coding for CPTs 29820 and 29821. Thanks for joining me for this explainer. Keep your documentation precise, and as always, decode healthcare with Harshal.